Hi everyone, welcome once again to AARC's Big Ideas Theater. I'm your host, Ed Highland. I have the honor now of being joined by Dr. Richard Casaburi. He spoke earlier today on a session about pulmonary rehabilitation. Doctor, thank you so much for coming by, and give us, if you would, first of all, just kind of the benefits in an overview situation of pulmonary rehabilitation.
Well, you know, I was really honored to present a lecture today in honor of Tom Petty, who was the originator of pulmonary rehabilitation, really the father of rehabilitation. And the field has grown since he did his sort of seminal work 30 years ago. Pulmonary rehabilitation actually has an awful lot of benefits. It does things like improve exercise tolerance. It improves quality of life, health-related quality of life. It improves dyspnea of patients. And these are things people care about. They really care about these problems, these really poor people who we try to help. And it does them to a degree that's greater than any other therapy we have. So I think that's really important to know. It also decreases exacerbations of COPD, decreases depression and anxiety, improves their ability to get around and do things in their everyday life. These are really important benefits, and they're really unquestioned. Guidelines recommend pulmonary rehabilitation up and down, standard of care very, very clearly.
Why then, mentioning all these benefits, does it seem that pulmonary rehabilitation doesn't get the love, so to speak, that other COPD therapies do?
You're exactly right, and I in my lecture I went through a sort of a detailed argument why that's probably so. If you consider the three major therapies, we have bronchodilators, cornerstone therapy for COPD. We have oxygen therapy for a minority of patients, but very important for them. And then we have rehabilitation. Well, if you compare their magnitude of benefits, actually rehabilitation in the things we think about in exercise tolerance, quality of life, all does better than all of them. Yet if you go and do a survey and find out how many people get these benefits, you find that almost all patients with COPD who are diagnosed will get bronchodilator therapy. All patients who qualify for oxygen will get it, have it in their living room, but only about someplace in the range 1% to 3% of patients who would benefit from rehabilitation actually get it. Now, why is that? What could possibly give you that discrepancy? Well, as I said in my lecture, I think there's a couple of reasons. Well, what do bronchodilators have that rehabilitation might not? Well, bronchodilators have marketing. They have people who go to doctors' offices. They have on TV, you can see advertisements for bronchodilators. Patients see those, physicians receive that information, and they prescribe them. Oxygen therapy, interestingly, doesn't have marketing, but it has survival advantage. It was shown by Tom Petty 30 years ago that people who don't receive oxygen therapy and their oxygen levels are low die much more frequently, much higher numbers than people who receive oxygen therapy. And survival advantage is a special place in the paradigm of benefits. You know, Mrs. Jones, you have this disease. We have a drug that will prolong your life, but we're not going to give it to you. You can't do that. You don't do that. So oxygen therapy has very big penetrance, despite the fact that it doesn't have the marketing. And all these therapies are about equal expense. It's not that one's way up here and the others are down there. They're all moderately expensive, but not very expensive therapies. So why doesn't rehabilitation succeed? Well, it doesn't have the marketing, and probably will never have the marketing. It doesn't have the survival advantage. The literature is not clear on it because the trials to show that survival advantage haven't been performed. I presented some literature with trivial numbers of patients in it, which suggests there might be a survival advantage, but nobody can take that and really say this is the case for rehabilitation. And the experts believe that it does. They believe it does improve survival.
Now, having said all that, what's the future then? Where do we go from here?
Well, yeah, that's it's a big mountain we have to climb, a big road we have to travel to, in effect, document that rehabilitation does improve survival, and also that it decreases admissions to the hospital, which is another important outcome. And there's some of us who are working hard to get a trial like that funded. And for these trials, we can't go to the pharmaceutical companies. They're not going to fund this. We have to go to federal funding, NIH, to fund what would be a fairly big trial. And we're trying to form this up right now with several thousands of people, probably after a COPD admission, entering rehabilitation versus not entering rehabilitation, and see who dies first, essentially. And it'll probably take us 5 to 7 years to do this trial, and we don't have the money for it yet, but we're trying. And I think that if this trial was positive, and the New England Journal of Medicine came out with a statement, pulmonary rehabilitation improves survival, that patients would demand it, physicians would demand it, and payers would realize it's in their interest. And that's what I'm hoping for. It'll take a while to get there, but that's what I'm hoping for.
We'll keep our fingers crossed and our lungs full, as it were. So,
very good, very
Dr.
good.
Casaburi, thank you so much for coming by and joining us in the Big Ideas Theater.
You're very welcome. Enjoyed it.
And this is the ARC Big Ideas Theater. I'm Ed Hylett. Thanks for joining us.